lateral and medial femoral and tibial epiphysis. And I can see some lucences in the frontal radiograph on the fibular lateral aspect of the mid-tibial diaphysis. The
recording has stopped. This meeting is being recorded.
The lesion shows sclerosis, well-defined sclerosis in the frontal radiograph. So this is a mixed sclerotic lytic lesion in the mid-diaphyseal, metadiaphyseal region of the tibia with some asymmetry in the knee joint and bowing of the frontal bowing of the tibia. So does the patient under fever, so I would put my infective etiology as the first differential. And
did you say infection?
Brody's abscess.
Okay.
Or
is this a typical location for infection?
No, it is not. And
where would you tend to see infection or Brody's abscess?
Why did I say Brody's? It would be more of tibial distal tibial metaphyseal or proximally. Could it be? I cannot think of a mixed sclerotic lytic lesion in an skeletally immature patient and child.
So don't worry about what the diagnosis is. Okay, I just don't worry if you don't know what this is. I'm not concerned by that. I'd like you to concentrate on whether you think this is aggressive or non-aggressive.
So it has caused a bowing of the tibia. Had the patient inherit the skeletally deformed bone, I would say the lesion is non-aggressive because I cannot see any periosteal reaction, soft tissue swelling, or
okay.
There's a narrow zone of transition. I can see the inferior lateral borders, the inferior medial borders, superior borders, yeah.
Yeah, good. Okay. So you're not seeing any aggressive features. You don't know what it is, and that's okay. That feels uncomfortable, but that's okay. You're trying to develop a safe framework. So when are you worried and when are you not worried? You're not really worried. You can see that there's bony deformity, there's bowing of that tibia. And actually, if you look really hard at the anterior cortex on the lateral view, can you see anything along the anterior cortex?
Yeah, I see a lucency. So I was worried whether there's a fracture because of the sort of torus or something buckling sort of.
Okay.
Yeah, lucency. And also I can appreciate maybe it is an overcalling in the distal tibial epiphysis. I could see a thin linear lucency.
Okay. So we're thinking that the patient may have had a previous fracture.
Mm-hmm.
Does the MRI help you at all?
Yeah, so now the lesion has overgrown its origin and extended a bit into the soft tissue with an exophytic component. And it's T1 hypo and mixed intensity on T2. With subtle edema on the medial, but I can see the lateral cortex to the fibula. I can see it well defined, but the medial cortex is encroached and destroyed. And
so actually, do you mind if I stop you? Is that okay? Actually, the cortex is thickened. You have what looks like endoscalloping.
Sorry.
Yeah,
T1, I can see the cortex well defined. It is basically growing into the cortex. So, osteoblastoma would be my differential now.
Sorry, what was that?
Osteoblastoma, but it's not a typical location for it. Is it a diaphyseal and cortical osteodostoma?
Okay.
Yeah.
So there are a few things that you can get in the tibia, and they're tricky. So in a pediatric population, we're thinking about osteofibrous dysplasia, fibrous dysplasia. This is a nice example of osteofibrous dysplasia. It has that mixed density. You have that nice sclerotic margin with a slightly fibrous component internally. There's no real aggressive features that the patient did have previously, a pathological fracture. We could see that nicely in candidate 2. It described that really nicely, where there was thickening and a linear lucency within the anterior cortex. Around 50% of these occur under the age of 5. They tend to occur within the diaphysis. And you do have that nice sclerotic margin generally. It's very difficult to differentiate osteofibrous dysplasia from an adamantinoma, but the age does help to be a discriminator in those cases. These tend to go down to bone tumour centres and have biopsies, but there's nothing really that aggressive on the plain film. It was really trying to see that evidence of the previous fracture and trying to link that maybe the pain may be coming from that. Candidate 1, on the same theme.
Okay. I see this is an radiograph of the femur. I see there is a wide expansion of the intertrochanteric region and the proximal shaft of the femur. There is a ground glass delicacy of the medullary cavity with expansion. There is no cortical breaching. The upper end is showing clear edge of the pathology. The lower edge is continuous, not ill-defined, no soft tissue mass. I will going with in this region. I will going with fibrous dysplasia, more likely for me. Also, in this region, also what's called here is the specific lesion here is one of the fibrous lesion coming in this region. It is not aggressive lesion. This is benign one.
Good. Okay, excellent. So yeah, this is a nice example of fibrous dysplasia. They usually are, they can be mildly expansile, and you get that nice kind of ground glass, that smudged appearance internally, which is that matrix, that fibrous matrix. It tends to be poorly organized. You're seeing this kind of smudged appearance. It can occur as a monostotic pathology or polyostotic, and there are multiple syndromes associated with those, which I'm sure you've all heard about, McKean-Boyce, Mazabrans, and you can get associated limb length discrepancies. Really nice example on the plain film, nicely described by candidate 1. And you can get the associated bone deformities, so that varus femoral neck, which is otherwise known as the shepherd's crook. A kind of good note just to put in here is, so the first image shows a nice example of the shepherd's crook deformity. The second image shows a lesion which I'd like you to be aware of. It's a used to be called a lipo. Oh, sorry.
Okay. Sorry.
So the lesion on the right used to be called a liposclerosing myxofibrous tumor. It's now thought to be on the spectrum of fibrous dysplasia. So it's just to be aware that those lesions tend to occur in the intertrochanteric or femoral neck lesion, and you can see that densely sclerotic focus centrally. And they tend to be a little bit more well-defined with the sclerotic margin. You can see the differences with the two images side by side there. Candidate 2?
Yeah, so I'm given with the frontal and lateral radiograph of right ankle joint of a skeletally immature patient with foot scene. I can see well-defined eccentric cortical-based lytic lesion in the lateral distal cortex of tibia, and with well-defined sclerotic medial margins, narrow zone of transition, no periosteal reaction, and some deficient cortex on the superior part. No soft tissue swelling, and no other lesion. So based on the appearance and location, my differential would be osteoid osteoma.
Okay, can I ask you just to tell me if you think this is aggressive or non-aggressive first?
It has caused a bit deficiency in the cortex, but based on the location appearance, I would still designate it as non-aggressive.
Good. Okay, so non-aggressive. Tell me what you know about an osteoid osteoma. Why do you think this is an osteoid osteoma?
It's based on the cortical location, but it's not that diaphyseal. Yeah, my second differential would be a non-ossifying fibroma.
Okay.
8, yeah.
Okay, good. So we'll come on to osteoid osteomas later. But you nicely described the non-ossifying fibroma in this distal tibial metastasis. They tend to be long lesions, eccentric in place. And this is a nice example of what's described as a bubbly lucent lesion. They tend to have that sclerotic margin. There's no periosteal reaction or really aggressive features associated with the lesion, as you really well described. When you follow these up, or when you incidentally follow these up, they tend to become a little bit more sclerotic until they completely remodel to normal bone. They are also known as fibroxanthoma, fibrous cortical defects. They're all on a spectrum of the same process. They're benign fibrous lesions. Really, the differentiator here is how large the lesion is, and that really decides what you call it. But a nice example, well described. These can be associated with neurofibromatosis type 1 and Jaffe-Campanachi syndrome. So just to have that in the back of your mind when you see multiple non-ossifying fibroma. I think we're on candidate 1.
Okay. Okay. This is a frontal radiograph of the knee, left knee, and AB and lateral radiograph. And following the cortices of this immature skeleton, I see includes the cortices of the femur. I see the cortice is continuous, complete, and following the tibia and fibula. The most worrying for me is there is in the right medial condyle of the femur, there is a rounded lucent lesion in the right femoral medial condyle with thin sclerotic margin. It is well defined. I see some soft tissue swelling. However, I don't see any evidence of effusion in the concerned joint space. I am worried about, for this young age, I'm worried about infectious pathology. This could be broad abscess. I need to do MRI for more delineation and delineation and characterization for this pathology.
Any other differentials that you know of lucent lesions that occur in the epiphysis that you would include in your differential?
Other differential for lucent lesion in the epiphysis could be this what's called chondroblastoma for this region in the immature skeleton.
Excellent. Yeah, excellent. Well done. Nice description and really good differential, like sensible differential there. So this is a chondroblastoma. They tend to be tumours arising within the epiphysis of skeletally immature patients, and they generally affect the age group between 10 and 25. They tend to be really well-defined lucent lesions with thin sclerotic margins. And the differential really to be aware of here is the clear cell chondrosarcoma. It's a very rare low-grade variant of a chondrosarcoma. It also arises within the epiphyses, and really it's only the kind of discriminator here is age. And this is just to show you an example of what that would look like. So the plain film, you can see that fairly similar lesion really. If you have an AP radiograph, this patient is 35. You can see that well-defined lytic lesion with the sclerotic margins, just as we did in the case before. And actually this lesion was picked up incidentally. The non-contrast CT in the top corner has an arrow pointed to the punctate calcification, which is the internal matrix of the lesion. It's really well defined. You can see that surrounding sclerosis. And then the MRI images at the bottom, just once again showing that this is a really well defined lesion with a thin sclerotic rim. And this was proven to be a clear cell chondrosarcoma. Candidate 2.
So I'm given with a frontal radiograph of the pelvis of a skeletally immature patient with a gonadal shield on. I can see fairly defined sclerosis in the right proximal metadiaphyseal region of the eccentric cortex, and some lucency in the neck of right femur towards the trochanter. So this cortical based sclerosis with some internal lucency points towards the first differential of osteoid osteoma. The lucency, I'm not sure whether I'm overcalling or is it a lesion in the femoral neck.
This is are you talking near the greater trochanter?
Yeah.
Yeah, I think that's directional. So tell me, what would you expect to see on the MRI?
So this lesion would show me the nidus, the sclerosis lesion, and the MR.
So that is what you're looking for. What would
more it would manifest, more it would be seen to me as an edema of the bone.
Good. Okay. So you tend to see on the MR the reaction, right? You tend to see diffuse marrow edema. Which modality would clearly show you the nidus?
So bone. So for nidus, it would be CT.
Okay, good. So here you can see a nice example of that cortical thickening, the surrounding sclerosis. And the central nidus in the middle of that, so really well identified on the plain film. And you can see how this looks very different to the non-ossifying fibroma that you described before, candidate 2, yeah? Mm-hmm. So this is a bone-forming tumour. You tend to get that really thickened cortex and that adjacent sclerosis that we're seeing nicely on the CT and the plain film here. Whereas in that non-ossifying fibroma that you described, that cortex was really thin, and it was really well defined, and you can see how ill-defined the osteoid osteoma looks in comparison. I hope that's helpful. Mm-hmm. Okay, summary slide. So we've already talked a little bit about it. The helpful information, if you can ask, is whether they have night pain, which is helped by non-steroidal analgesia. And these can occur anywhere, and we've got some great examples of them occurring kind of within the medullary cavity and intra-articular. These can occur everywhere. So in a case of a patient with pain, diffuse marrow edema, this should be up there with infection as a cause. You tend to see that nice lucent nidus which can have central sclerosis within it. And again, if you're lucky, the nidus tends to be small, so you don't always actually see it on the MR. The CT is really the clincher here, particularly in that case. And I'll just show you a couple of additional examples here of an osteoid osteoma. And you can see on the axial imaging, the last image here, how thick that reaction and that sclerosis is, where that nidus is sitting, and that kind of reaction that it's caused. Move along. So I think it's candidate 1.
Okay. This is an MRI in axial cuts of the brain. In the first one, left side, is the one suited image. I see there is right frontal midline extra-axial hypo-intense well-defined mass. I think it is in T2, it is showing a high signal with internal low signal. And I think this is the right side contrast study showing well-defined, well-enhanced margin with low signal in the middle.
Good.
This demonstrated this. Okay. Okay. In bone window, this lesion frontal showing beveled edge with narrow lumen of the internal diplo and soft tissue component sequestrum in front of it, as demonstrating in the 3 volume rendering, and in soft tissue here in the sagittal view, showing enhancement of peripheral enhancement of the margin of this pathology. I think this is eosinophilic granuloma lesion in this age group, and this is pattern of bone appearance in the bone.
Lovely description and